So I'd like to welcome viewers from across Canada and other parts of the world to what promises to be an informative session. Scleroderma is a complex disease, and it is important that we learn as much as we can, and it is great that we can do that together this morning. Before we begin, I'd like to make it clear that Scleroderma Manitoba in no way endorses any drug or treatment shared within this webinar, and it is always recommended that you discuss any medication and treatment with your physician for proper evaluation and treatment. With that out of the way, I'm thrilled and grateful to Dr. Mann and Dr. Wu, who have taken time to present to the Scleroderma community this morning. I've asked Debbie Robitaille, a member of the Scleroderma Manitoba patient support team, to introduce our speakers this morning.
Good morning. Dr. Mann completed her internal medicine residency at the University of Toronto and her rheumatology residency at the University of British Columbia. She then spent 2 years at the Boston University Scleroderma Research Center for a research fellowship with an emphasis in epidemiology relating to scleroderma. She lives in Winnipeg and practices general rheumatology with a special interest in scleroderma at the Manitoba Clinic. She is a member of the Canadian Working Group for Stem Cell Transplant in Scleroderma. She is also an assistant professor of medicine with the University of Manitoba. Dr. Wu completed his MD medical residency and adult gastroenterology fellowship at Queen's University in Kingston, Ontario. He then completed an advanced fellowship in gastrointestinal motility at the University of Calgary. He is currently at the University of Calgary and serves as the co-director of the Gastroenterology Function Lab, as well as program director of the Gastroenterology Motility Fellowship, and as a clinical lecturer at the Faculty of Medicine. His research interests include connective tissue disease and gastrointestinal motility. Both Dr. Mann and Dr. Wu's complete biographies are on the Scleroderma Manitoba website.
Okay, well, thank you for that introduction. I think I'm going to go ahead. Is that right, Debbie?
Correct.
Okay, all right. So thank you so much for that introduction. I'm very happy to be here and to be able to talk to all of you today. And I just want to say a special thank you to Scleroderma Manitoba for having me here. I'm just going to take a minute here to get my slides up on the screen. All right, so as you can see here, let me just do this. As you can see here, I'm going to be talking about not only about swallowing, which is the main topic of today's education sharing, but I'm going to introduce you to how scleroderma affects the gut in general. I think it's important probably to have an overview of that, and then we'd focus on the swallowing part of things. So to introduce the topic, I just want to let you know that the gut is involved in a large majority of scleroderma patients, in up to 90%. And not everybody has symptoms from this, but about half or even more do. And these symptoms of the gut in scleroderma can include trouble swallowing, heartburn or reflux, bloating, diarrhea, constipation, lack of appetite, weight loss, and fecal incontinence or stool leakage. Gut involvement in scleroderma can occur both in the two subtypes that you may know of, diffuse and limited. And there's some literature showing it may be more common in diffuse subtype patients. Gut involvement can also occur at any time during the disease, early or late, but maybe even the very first symptoms that leads one to get diagnosed with scleroderma in about 10%. although it is very common, it's encouraging that severe involvement is rare, about 8%. And we know that no matter how mild or severe, it can greatly affect quality of life and function. This includes everyday activities, varying from ability to work, and impacts greatly on emotional and social well-being. So it's an important topic to understand. So for today's talk, I'm going to be obviously sharing this topic with Dr. Wu. I'm going to be focusing on the anatomy of the GI tract and how really biologically, mechanistically, scleroderma can affect the gut, the types of gut involvement in scleroderma, and specifically then at the very end, how scleroderma can affect swallowing. So this is a kind of a cartoon version, a diagram of what the gut, the part of the gut that we're going to be talking about looks like. And as you can see, I've also included the mouth and the throat because we're talking about swallowing here. And although not technically part of the GI tract, it is the very beginning of it. And then, so food goes into the mouth and throat, goes into the esophagus, travels down through a sphincter that normally acts as a gate into the stomach, where some of the digestion happens with acid and movement of the stomach. It squeezes into the small intestines, where nutrients are absorbed, and then goes into the large intestines, where a lot of the water resorption occurs and stool is formed, and then is held in the rectum until it's ready to be passed. An important concept to understand in order to understand scleroderma in the gut is that the GI tract is a long muscular tube. Now, we often think of muscles as, you know, in your arms or in your legs, but we also have different kinds of muscles within our internal organs, such as our gut, where they're not obviously not voluntary. We can't control them. So they're called smooth muscle, but they're muscles nevertheless that can squeeze and relax and squeeze and relax. So here is kind of a slice of across the tube, this GI tube, and laying it down flat, whereas this top part is the surface where the food meets, and the bottom is where the muscles are. And I wanted to show you this diagram. It's very complex as a medical one, but I just wanted to show you that the major problems that can affect patients with scleroderma in the gut. And there's some theory that it probably stems from poor circulation or problems with the blood vessels. I'm sure a lot of you have what's called Raynaud's, and that is an example of when blood vessels get affected in scleroderma. So they spasm, they don't perfuse as well. And the same thing can happen in the gut. So if you don't have enough blood supply in the gut, then eventually you could have nerve damage because the nerves need blood as well. And so you can imagine if you have nerve damage, muscles can't coordinate to contract in a coordinated fashion. So it's like multiple different muscles moving differently or weakly, and they can't produce a good contraction to push food down the GI tract. Lastly, muscles themselves can also be affected by scarring. Scleroderma is characterized by fibrosis, as you know, in the skin and the lungs. It can also happen in the GI tract. And so as a result, the tube can become more stiff rather than elastic, rather than being able to be stretched and bounce back. It becomes more loose and doesn't contract as well. So all this to say, to really focus on the fact that there is this constant squeezing movement down the GI tract that's very important to the function of it, to push food down and secretions down, and that's called peristalsis. This is kind of an illustration of it. Let's say if you ate a piece of bread, turns into a bolus, that distension of the GI tract then pushes it back down in kind of like as if you're squeezing toothpaste. out of a tube. And this is an illustration of recording of muscle activity within the GI tract. And I'm sure Dr. Wu will go into this in some more detail, but it's just to show you a more severe example of what can happen in the Scleroderma GI tract, where these spikes represent contractions of the muscles. And you can see that it's not there within the esophagus or in the gate, the lower esophageal sphincter between the esophagus and the stomach. You don't see the same spikes. Within the throat or the pharynx, you still see the spikes, and that's to illustrate that most often it's not a problem of the throat, but more often esophagus, although sometimes it can be of the throat as well. So as a result of the weakened and stiffened gut muscles, food and secretions don't get pushed down like they're supposed to. And then some of these disorders can happen as a result that you can see on the right side. So trouble swallowing, 50 to 60%, acid reflux, 70 to 90%, gastroparesis, and I'm going to go over these in more detail in the next coming slides. Gastroparesis or lack of gastric emptying from the stomach. Small intestinal bacterial overgrowth can affect the small intestines, constipation with the large intestines, and fecal incontinence. So the first manifestation I want to focus on is heartburn. And heartburn is also called acid reflux or GERD. It's when stomach acid, which is normal and good and supposed to be there to help us digest and to keep bacteria out, this acid's supposed to stay in the stomach. But when the gate between the esophagus and the stomach is loose, and you don't have good contractions going downwards in the stomach or in the esophagus, the acid can backflow into the esophagus and cause problems. And this can lead to a burning feeling in the chest after a meal, especially when you're lying down flat at night or anytime after you've eaten, or even when you're bending forward. It can lead to an acid taste in the throat or mouth, or a burping feeling after you eat. Another thing to note about heartburn is that not only is it uncomfortable, but prolonged acid irritation in the esophagus is also not very good for you, in that it can lead to inflammation, ulcers, bleeding, and what we call strictures or narrowing parts inside the esophagus. And strictures can definitely make it hard to swallow as food can't go down properly. Going down in the GI tract, next is the stomach, and what I refer to as gastroparesis or delayed stomach emptying. When the stomach doesn't push food down as fast as it normally should, you can feel bloated or feel full really easily, really fast. You ate a couple bites, you thought you were hungry, and you're already full. Or it's been hours since you last ate and you still can't really eat again. It can sometimes lead to pain, nausea, vomiting or regurgitation of undigested food. And as you can imagine, if you have backup down the pipe, you're going to have more heartburn too. Again, this is something that I'm not an expert in, Dr. Wu is, but just to illustrate a gastric emptying study. And so half the contents in the stomach, so this represents food in the stomach, this orangey, greenish blue stuff. And it should be gone by 90 minutes. And the bottom part is the intestines, and you want to see it there after several hours. But as you can see in normal gastric emptying, a lot of it is down in the intestines, and in delayed gastric emptying, it's still sitting in the stomach. So there's just an overlay to let you know what it's referring to. And then in the middle of our abdomen, there's our small intestines. And one thing that can happen with slowed movement down the gut is that is small intestinal bacterial overgrowth. So normally the small intestine has really little bacteria. The large intestine, in contrast, is supposed to have a lot of bacteria. It helps the stool forming and digestion process. In scleroderma, due to the slow movement of the small intestine, Now the bacteria have a chance to grow, and bacteria that's not normally there have a chance to grow. Just like pools of water, you get lots of mosquito. That's kind of mosquitoes. That's an analogy. So these bacteria eat the food that's in your small intestines and expel gases as a byproduct. And these gases extend the small intestine, leading to bloating sensations, nausea, and then because of all the byproducts, it can also lead to diarrhea. And as you can imagine, if the bacteria are eating your nutrients, it can also lead to malabsorption and malnutrition. Constipation, down further in the large intestines, slowed motility leads to decreased bowel movements and drier and harder stools. The definition of constipation is less than 3 bowel movements per week. Severe, less than 1 per week. Again, can lead to abdominal pain, bloating, a feeling of incomplete emptying after you've gone to the bathroom. And paradoxically, it can lead to diarrhea too, because when you have something stuck in the front of the outlet that is not coming through, you can have liquid stool coming from behind it that goes over it and leads to diarrhea, and we call that overflow diarrhea. This prolonged expansion of the intestines that is not supposed to be there can lead to, and straining when you're trying to go to the bathroom, can lead to little pockets in the large intestines that again can sit there and be an area where bacteria can grow and cause irritation. And at the very bottom of the GI tract is a problem called fecal incontinence. This is the decrease in ability to control bowel movements, causing stool to leak unexpectedly from the rectum. And obviously it can be very distressing and greatly reduce quality of life. There's a reluctance, of course, to discuss this with others or to one's doctor, but actually is not uncommon in scleroderma. And there are strategies to help. So this is due to a combination of factors in scleroderma, including a thinned internal anal sphincter. This is kind of, again, a gait that requires the muscles to contract and hold. And because the muscles and nerves are weakened and damaged, and also because it's stiffer, it becomes not very functional. And again, a recurring theme, the loss of nerve damage can lead to reduced anal sensation and the normal reflexes that are required for this function. And to compound the problem, if you have, let's say, small intestinal bacterial overgrowth and you have diarrhea, that can lead to more leakage. So finally, to the topic of today, trouble swallowing. So as you can already imagine from what I've just talked about with you, you can imagine that if the tube is stiff and weak and it's not pushing it down, that's one of the causes why you can have trouble swallowing. And as I mentioned, if you have irritation of the esophagus from prolonged acid reflux, and strictures, then that can be another reason why it might be painful to swallow or food might get stuck. But another reason why could be because of problems in the mouth itself and also in your throat. It's less well understood, and that's why I think a lot of you might notice that your doctor may not talk about that aspect as much. But a lot of research is going into this, and a lot of allied health care professionals, such as physiotherapists, occupational therapists who have special interests, and speech language pathologists who have special interest in this, will be able to help as well. So what happens in the mouth and throat? So first, very commonly, scleroderma patients can have dryness in the mouth. They may even have an overlapping autoimmune problem called Sjogren's syndrome that also causes dryness of the mouth. But even without that extra diagnosis in scleroderma, this one study, for example, showed that about 63% of the group that they studied had dry mouth. And that's usually because of reduced saliva production. Saliva is necessary to maintain healthiness of your teeth. And so this can also lead to poor teeth, dentition health, dental health, and that can make it obviously difficult to chew as well. And dryness leads to lack of lubrication for the food bolus to be swallowed. Small mouth opening, as you can see in the picture here, affects 50 to 80% of scleroderma patients. And this is due to skin tightness, but also tightness of the tissues underneath the skin, tightness of the muscles around the face, and tightness around the jaw muscles. In inflammatory jaw arthritis can happen, although less common. Nerve damage inside the mouth, like neuropathy of the tongue or inside the mouth, leading to poor sensation, which is needed for coordination of swallowing, can also occur. And at the very back of the throat, we call it the pharynx. There's muscles that you can actually control, because if I asked all of you to try swallowing it right now, I think you could. But this coordination and the control of that muscle can be disordered in scleroderma, especially in patients who also have an overlapping problem with inflammation in the muscles called myositis. And there's some thought that if you have prolonged reflux, that those muscles may also tighten. So here's just an illustration of what I talked about, where there's different phases of swallowing, not only the esophageal and the lack of pushing it down, that might be a problem, but problems within the mouth, within the throat. I didn't go into anything about diagnosis or treatment within the talk so far, as Dr. Wu is going to go into that further, but I thought I'd mention some non-pharmaceutical or non-medicine type of management strategies about how to deal with trouble swallowing, or what medically we call dysphagia. So it's important to know that exercises for mouth opening can actually be very helpful. And I'll show you a website where you can find videos on how to do that in just a minute. Keeping good dental hygiene would be very important, especially with that dry mouth and lack of saliva I just discussed. So making sure you're flossing regularly, brushing your teeth. Regular follow-up with a dentist that you trust, somebody who's willing to learn about scleroderma, or somebody with already expertise in scleroderma would be important. Keeping well hydrated, keeping water with you all the time, and especially when you're eating food, is important. And knowledge of some of these over-the-counter dry mouth products is also very useful. So there's artificial saliva dry mouth products, special toothpaste for patients with dry mouth, etc., or little tabs that you can put in your mouth to help the saliva. That all can help. It's important to get to know yourself in order to really adapt to these issues. So get to know which foods are tough for you to swallow and try to avoid those things. Keep a diary of these things. Keep a diary of what makes it, what causes worsened reflux as well. When you're actually eating, make sure that you take small bites of food. Don't rush. Chew thoroughly. Sometimes it may actually help to swallow more than once before you take that next bite, so that you don't overload your system, which is a bit weaker and slower. And always ensure that what you're eating and what you're choosing on the menu when you're going out is moist and soft. So well-cooked foods are probably better than raw foods, for example. Safe eating techniques are important, such as having good posture when you're eating, reducing distractions, again, not rushing. And consulting with a swallowing specialist can also be useful. So these are speech language pathologists. I know their name doesn't say anything about swallowing, but some of these people also specialize in swallowing. If your dysphagia or swallowing problem is severe and you need extra nutrients, you may want to talk to your doctor about supplements that are softer or liquefied, like Ensure. And it's important to keep your reflux at bay by using medications prescribed by your doctor. and also lifestyle changes, such as elevating the head of your bed at an incline, not eating late, eating smaller meals more frequently rather than bigger meals, and sitting up straight after your meals. I think I'll give this to Geraldine maybe later on to distribute to anybody who's interested, but these are a couple of websites that are very, very useful. The top one is somewhat newer, called selfmanaged-scleroderma.com, and it has a number of different topics, both written out and also videos, including mouth and hand exercises, and all about dysphagia or trouble swallowing, and as well as GI involvement in scleroderma, and similarly with the Hopkins Scleroderma website. So in summary, what I've talked about in these last 20 minutes or so is gut involvement in scleroderma is common and may be underreported. The mechanism, the majority of the mechanism is due to weak and stiff gut muscles where food does not get pushed down in a coordinated manner. Any part of the GI tract from the mouth to the anus can be affected, but the esophagus is actually the most common site in scleroderma to be affected. Trouble swallowing can be due to many factors, including in the mouth, throat, and esophagus, but it's reassuring that there are actually many strategies that you and your doctor can employ to help improve the symptoms of the gut involvement in scleroderma. And with that, I thank you, and I'll pass it over to Dr. Wu.
Hey everyone, let me just quickly share my screen. Alrighty, so thanks again to Scleroderma Manitoba for inviting me to give this talk to you guys. So these are our objectives here. We're going to review some of the different diagnostic modalities and involved in the diagnosis of esophageal symptoms in individuals with scleroderma. We're going to get an approach to different causes of these esophageal symptoms. We'll discuss treatments, and then we'll briefly review gastric and oropharyngeal findings in scleroderma. So I'd like to thank Dr. Mann for her excellent summary of some of the physiology relating to swallowing. So in someone who's having swallowing challenges, whether or not they have diagnosis of scleroderma, the approach tends to be the same. We start with endoscopy. We look at doing barium swallows, and if these are normal, we may look at doing tests of esophageal function. So many of you may have had an upper scope in the past. So endoscopy is the gold standard way to evaluate swallowing difficulty. So in other words, anyone with swallowing difficulties probably should undergo one of these procedures. So in endoscopy, what happens is a thin, flexible tube with a camera at the end is passed into the mouth through the upper esophageal sphincter, down the esophagus, through the lower esophageal sphincter, into the stomach, and into the small bowel. Now, this tube contains a camera which allows us to see, but it also contains a channel by which we can do different procedures as well. So you can see here that there are different parts of the anatomy that we can see going down the esophagus. So here we can see what's called the lower esophageal sphincter at the gastroesophageal junction. That is the where the esophagus and the stomach meet. You can see this looks fairly normal. And then as we pass into the stomach, we can see the bottom of the stomach. This is what's called the pylorus, where the stomach meets the small bowel. And then here we've flipped the scope around to look at the top of the stomach. And you can see this black tube here is actually the scope. We're in what's called a retroflex position. And then down here, we've passed the scope all the way to the small intestine, and we can see the folds that tell us we're in the small bowel. So, knowing what these structures look like normally is a key to making diagnoses here. So this is what's called a barium swallow. In a barium swallow, what happens is the individual drinks a certain amount of barium, which is a radiopaque contrast dye. And they undergo a series of x-rays in a couple of different positions, and there are a couple of different protocols. Some of them involve looking at video of actually, the barium passing down. Others involve doing, the barium at different time intervals. But, ultimately, these are considered an adjunct to endoscopy. So, in other words, if you're swallowing difficulties, you should really undergo the endoscopy first to make sure there's nothing structural. So the barium swallow may show really very gross abnormalities, so really obvious things, and may give us a hint as to what's going on in terms of the motility or the movement through the esophagus. But really the key test here is the endoscopy. So again, I would like to thank Dr. Mann for her excellent description of esophageal function, particularly likening it to a squeezing out a tube of toothpaste, which I think is quite apt. So in patients who have persisting swallowing difficulties, despite a normal upper scope, we would then look at assessing the function of the esophagus. So, we've ruled out abnormalities of the structure, things we can see. So now we're looking at abnormalities of function. That is that movement of food through the esophagus. So the first step is what's called an esophageal manometry. So in this procedure, a flexible tube or probe with solid state sensors is passed through the nose, through the upper esophageal sphincter, esophagus, and into the stomach. And when the patient swallows, these pressures along the tube are actually converted into this heat map that we can see here. So this right here is the readings that an esophageal manometry would generate. So you can see up here, higher pressures are red and green, and lower pressures are blue. So you can see here, we have the upper esophageal sphincter that relaxes when you swallow, or when you initiate the swallow to allow the food bolus to go through. And then you have, the y-axis here being length along the esophagus, the x-axis being time. Over time, you have this nice sequential contraction that moves down the esophagus. And we know that it's sequential because you essentially are seeing this nice diagonal that's pushing the contents of the esophagus down. Down here, you see the lower esophageal sphincter, which for the most part is remaining contracted, but when you swallow, you have this reflex relaxation of the lower esophageal sphincter to allow the food bolus to go through. So you can note that this lower esophageal sphincter remains, again, at quite high pressures. And this is important because your lower esophageal sphincter is the main barrier to prevent acid reflux. So just a quick word on pH testing. So in some patients, they may have symptoms of heartburn and regurgitation that persist despite being on medical therapy. So in this test, a little catheter with acid sensors is passed through the nose, again down into the esophagus and into the stomach. And it's connected to this recording belt that has some buttons on it. So the patient goes home with this for 24 hours, and if they feel symptoms of heartburn, regurgitation, or even things that are less typical, like chest pain or belching, they push a button on the recorder. You can see over here, the tracing occurs over time, and this sort of zigzag blue line is actually the acid in the esophagus. So you can see at various points, the pH drops in the esophagus. This is acid reflux, and we're able to correlate the patient's symptoms with what's going on in the esophagus. And this gives us some information about why, you may be feeling the symptoms that you're feeling. So if you recall the normal looking manometry from a couple of slides ago, this is what we might expect to see in someone with scleroderma. So again, moving from the top to the bottom, you see this line of pressure at the upper esophageal sphincter, but when you swallow, we're missing this nice diagonal wave of red and green going across the esophagus over time. So what this means is there's no effective peristalsis. So like Dr. Mann said, if you can imagine, this peristalsis being like, squeezing this tube of toothpaste, there's actually no squeezing happening here, or the squeezing is happening in either an incomplete or an uncoordinated fashion. Now moving down, we can see that there's actually not a lot of pressure in the bottom of the esophagus at the lower esophageal sphincter. So, going back here, if you recall, this very nice continuous line of green, your lower esophageal sphincter, this is your main anti-reflux barrier. Here, it's quite discontinuous. We see these little blips of green. That's actually your diaphragm, the muscle that is between the thorax, the lungs, and the stomach, but there's actually no sphincter pressure here. So this is why you can have a lot of symptoms of acid reflux. So a majority of individuals with scleroderma have some form of esophageal dysfunction, but this is, this absent contractility, this very low pressure lower esophageal sphincter is what has previously been called Scleroderma esophagus. So we would consider this very severe esophageal dysfunction because of damage to the nerves and the muscles. And because of the damage to nerves and the muscles, you can see what's called dilatation, or the esophagus actually stretches out a bit. And this can lead to more challenges swallowing. So just a bit on acid reflux in patients with scleroderma. So again, very common, and it's made worse by a couple of different things. First of all, poor motility in the esophagus. The tube of toothpaste isn't being squeezed because of the poor clearance of the esophagus. You have acid staying in the esophagus a bit longer. Again, you have this anti-reflux barrier, this lower esophageal sphincter that is very weak, potentially non-existent, and you may have what's called a hiatal hernia, wherein the lower esophageal sphincter moves upwards, and this can happen because of shortening of the esophagus. And again, if your gastric emptying is delayed because of gastroparesis, gastric acid doesn't empty as readily, and it'll splash back into the esophagus. So again, a majority of individuals with scleroderma do have GI symptoms, but it's also very important to note that even if you're asymptomatic, you may have esophageal disease, either esophagitis or dysmotility. And the reason why this is important is it may contribute to progression of lung disease. We know that scleroderma is a multisystemic disease, and one of the manifestations is actually interstitial lung disease. So you can have these aspiration events wherein contents of the stomach go up the esophagus to the mouth and then back into the trachea and into the lungs, and it can lead to poor lung function. Complications of acid reflux. So just briefly, talking a bit about acid reflux, this persistent acid exposure can lead to a number of different things. One of the things it can lead to is reflux esophagitis. So Acid exposure or acid reflux in the esophagus causes inflammation and ulceration. And there are different degrees of acid reflux. So going from mild to severe, you can see here that you have a fairly normal looking lower esophageal sphincter with a bit of redness here. This is a bit of inflammation, but overall fairly mild. But as we go along, you can see how there's a bit more redness. You have redness and ulceration, and over here you have redness that pretty much encompasses the whole esophagus. So these degrees of inflammation are concerning because we know that inflammation leads to complications of reflux, strictures, Barrett's, and potentially cancer. So these have to be treated with acid suppressive therapy. And generally we would repeat a scope to make sure that these are gone. So esophageal stricture. So essentially what happens is with sustained esophageal reflux, you may have scar tissue at the bottom of the esophagus build up. So you can see here that the esophagus, it's very narrow. You can imagine you're barely able to squeeze through. You may not even be able to pass the scope, which is only, it's under a centimeter in diameter. So strictures are common due to how common reflux is in up to a third of patients. So in terms of the treatment of these strictures, we would, in addition to controlling gas reflux, look at doing what's called a dilatation. So in this dilatation, we've passed a catheter with a balloon down the scope, bridged the stricture, the scar tissue, and inflated the balloon. And you can see here that, again, the hole is a bit bigger. You have a tear in the esophagus. We would expect this, and we may go past the scope now. And other options include using what's called a bougie, which is essentially a tapered cone, which may be passed through the mouth down the esophagus, either with or without a wire. Now, there is a risk of perforation, making a hole in the esophagus with these procedures, about 1 in 500. It may be higher in someone with advanced scleroderma due to a thickening of the muscle. Barrett's esophagus is one of the complications of long-term reflux. So what happens with Barrett's esophagus is because of sustained acid exposure in the bottom of the esophagus, the cells in the esophagus undergo a change from these nice pink esophageal cells to this very dark salmon-colored cell. So this is actually intestinal cell. Another word for Barrett's esophagus is intestinal metaphasia. So why intestine? Because the intestine is used to having gastric acid in it. It's a very resistant type of cell. But the problem is whenever you undergo any transformation of cells, metaplasia, there is the risk of this process advancing further, causing what's called dysplasia and eventually cancer. So in this recent study published in the Mayo Clinic, up to 13% of women with scleroderma had Barrett's esophagus, but more concerningly, almost half had advanced changes in their esophagus, what's called dysplasia. And many of these patients had poor motility as well. And, the management largely depends on how advanced things are. If it's mild, you can watch it. If it's advanced, you may have to treat it through the scope. And of course, this is the complication we're trying to avoid of all this. This is esophageal cancer. You have adenocarcinoma, which occurs as a result of acid exposure, or you may have cancer in the mid-esophagus.
Dr. Wu, can I just interrupt you for a second?
Sure.
We've just had a couple of comments that people are having a little trouble hearing you.
Oh, sorry.
So if you could turn your speaker up or speak a little louder, that would be
okay. I'll try to speak up, and I do apologize. Okay. So, in terms of other things we may see in the esophagus, we may see what's called Candida or yeast in the esophagus, and this is largely driven due to poor motility, as well as in individuals on PPI, there may be less acid in the esophagus as well. And this may cause difficulty swallowing and is treated with antifungals. And do let me know if my volume is not high enough. So just briefly to build on to what Dr. Mann said, lifestyle modification therapies for acid reflux, they work well in the setting of mild and moderate symptoms. But in individuals with severe symptoms, especially those with really bad esophagitis or strictures, medications are generally needed. So proton pump inhibitors are very effective. These are medications like pantoprazole or rabeprazole. They block acid production in the stomach. So PPIs are more effective than, so H2 blockers are medications like ranitidine or Zantac or Pepcid. These medications are available over the counter and they work, but their efficacy tends to decrease over time. And these are both more effective than antacids, which have been shown in studies to be not very effective at all in the management of acid damage, because antacids only treat the acid in the stomach. They don't prevent the production of new acid. So it's important that these medications are taken regularly, 20 minutes before a meal. They need to be taken regularly because these medications, they need to be absorbed into your system to reach therapeutic levels and to block acid production from these glands in your stomach. And they're taken 20 minutes before the meal because your acid production actually starts before you eat in what's called the cephalic phase of digestion. Now, there's been a lot of concern in media regarding side effects of PPI use that do have a biological plausibility, things like dementia, osteoporosis, C. difficile leading or caused by decreased acid in the stomach. But it's important to realize that these studies tend to be studies that are observational, they're retrospective, meaning they take a look at large populations of patients and they look backwards at what medications they're on. And ultimately, when these studies are controlled for things that are called confounders, other conditions that may affect interpretation of these associations, the relevance of these risk factors becomes unclear. So our position is, you should be on the lowest effective dose to heal esophagitis. So just a bit on prokinetic agents. These medications, I say theoretically, improve esophageal motility by binding to receptors in the GI tract to improve peristalsis. Now, I say theoretically because a lot of these medications have not been studied in individuals with scleroderma. Buspirone, which is an old antidepressant, was actually studied in patients with scleroderma and did improve some aspects of motility without improving peristalsis. But unfortunately, a repeat study did not reproduce these effects. And conceivably, in people with very severe esophageal dysfunction, these medications may not work as well. Anti-reflex surgery involves wrapping the top of the stomach around the esophagus to augment the lower esophageal sphincter to make the anti-reflex barrier stronger. In many patients with scleroderma, they may develop dysphagia after this procedure, especially if your esophageal function is weak. And because your anti-reflex barrier is so weak at baseline, the sustained improvement does not last as long. So for that reason, most people wouldn't operate in this setting, the exception being lung transplant, where the key is, you really want to control the acid reflux to protect the lung. And there has been an interest in stem cell transplant, which has been shown to improve other manifestations of scleroderma without really, well, it may or may not improve esophageal motility. We're not sure yet. We're currently doing a study here in Calgary, but we're still early on in our recruitment. So I'm running a bit short of time, so I'm just going to quickly chat about scleroderma in the stomach. Gastroparesis, again, we have retained food on a gastric emptying study, which is a nuclear study wherein you sort of eat this standardized meal that has eggs and some bread and some other stuff. And the reason why it's important to have a standardized meal is we know that things like fiber, fat, all of these affect your gastric emptying. So on this basis, to prevent gastroparesis, you might want to decrease the fat in your diet and have smaller meals. Prokinetics may work, and there's poor evidence for other things. And here you can see this nice picture of a stomach full of food. And this is despite an overnight fast. You may be familiar with what's called GAVE, where we have these blood vessels in the stomach. Generally not too much to worry about unless you become anemic, in which case you would treat sort of with cautery through the scope. And again, in the mouth, I'm just going to focus on the fact that in individuals with scleroderma, they may have reduced salivary production, which may worsen reflux because part of saliva is sodium bicarbonate, which can neutralize that acid. And as well, there is a lot of swallowing dysfunction that's seen in scleroderma, where individuals may have difficulty initiating swallow. They may sort of have food in the mouth after the swallow, or they may actually have food go down the wrong tube into the lungs, causing coughing. And as Dr. Mann said, there's a role for a speech-language pathologist here, both in the diagnosis and exercises. So some take-home points of my presentation. I do apologize for going a bit over time. Esophageal manifestations are common, and the gold standard is the upper scope to rule out the really bad, the sinister stuff. Ultimately, the goal is controlled reflux, because in really advanced esophageal dysfunction, we may not be able to control or to do much about the peristalsis, and PPIs are safe and effective when used in the right situations. So with this, I would like to open it up to questions.
Okay, I'll invite Dr. Mann back. And there are a number of questions in the Q&A. So the first one that came up early was, are hiccups a common symptom?
So I can speak to this. So hiccups, I would say, so hiccups are complicated, largely because we don't 100% know why people have hiccups. And there are a number of reasons as to why you may have hiccups, some of which relate to sort of irritation of some of the nerves that control the diaphragm. But hiccups may be a presentation or a manifestation of reflux. So in the patients who I see who do have hiccups, one of the things I do try is very aggressive acid suppressive therapy to really try to control acid reflux.
Okay. Should I read them, Geraldine, or did you want to?
Sure. Or I can read the next one. Is there anything you can recommend to keep the mouth moist?
I can try this one. So lots of water. And so a lot of my patients will carry around a small bottle of water with them everywhere. Sour candies that are sugar-free can often be very helpful. And I say sugar-free just because if you have lots of sugar, it's going to be bad for your teeth. So sugar-free sour candies. There are over-the-counter products. One of the brands I have heard of is called Biotene, and it's in the toothpaste aisle at the drugstores. So you can go there and kind of look at all of those kind of products. And there are sprays, there are tablets. My patients have generally given good reviews about tablets that they can put between their teeth and gums at night. One of the brands I've heard of is called Xylee Melt. And because at night and in the morning tends to be a really bad time for dry mouth, people wake up with their tongue stuck to the roof of their mouth. So that tablet really helps at night. But really the major thing is to just keep well hydrated and having water with you.
Thank you. The next question is, can you comment if increasing dietary fiber helps or hurts bacterial overgrowth in scleroderma?
Yeah, I can answer this one. So the thing about bacterial overgrowth in scleroderma is the driving factor is really the dysmotility. So I would say that your dietary fiber intake actually probably plays a relatively small role in things. I would say that, certain dietary fibers that we do use, things like Metamucil is a common one, sort of like a viscous soluble fiber that has been shown to improve constipation in sort of all comers. One of the side effects of this is bloating, but I would still recommend this in someone with troublesome constipation, over for instance, a laxative or something like that. Because if someone is able to manage their constipation with Metamucil, I probably wouldn't worry too much about the theoretical risk that fiber might hurt things. Now, the exception, being something like inulin, which is a prebiotic. These are medications, and to a certain degree, even things like probiotics. I would probably steer away from using these medications or supplements, only because we don't really know how it will sort of affect the GI tract, in the sense that how inulin or prebiotics work is they provide this like really fertile ground for bacteria to grow. So in someone with altered motility in the small bowel, there's the really theoretical risk of having things go awry. But to sort of directly answer that question, I wouldn't have any hesitation about recommending an increase in sort of soluble fiber in someone, with something like constipation. But again, warning them that, if they have symptoms of bloating, they may sort of wish to back off on it.
Thank you. In a similar question, we have, is there anything that can be done to reduce small intestine bacterial overgrowth?
All right, I could take this one as well. So, like I said before, the small intestinal bacterial overgrowth in Scleroderma is largely driven by poor motility through the GI tract. So, on that basis, the options when it comes to treating SIBO, one option is to sort of try to augment motility through the GI tract to sort of increase peristalsis through the small bowel using things like prokinetics. A common one is prucalopride. But again, especially in people with really severe disease, these prokinetics may not work as well if there's a lot of damage to the nerves and the muscles. Now, the other option is antibiotics, and personally, I find that antibiotics do work a bit better, and they've got a couple of different options. There's a common one called rifaximin, which is a non-absorbable antibiotic. But the problem, or I guess the challenging thing with managing SIBO in this circumstance is that the underlying cause, the driving cause for this motility is still there. So in these situations, you may have to go on repeated courses of antibiotics if the symptoms come back. But again, this is largely driven through either symptoms or whether or not there are things like nutritional deficiencies because of the SIBO. And I do have some patients who are on sort of cyclic antibiotics, so they'll be on 2 weeks of one antibiotic, and then when their symptoms worsen, they go on another 2 weeks of another antibiotic, and this is to reduce antibiotic resistance.
Thank you. Here's a question: how often should scleroderma patients have an endoscopy?
Sorry, I guess I can take this one too. So the problem is there are no good guidelines on this sort of thing, and this is largely because there are so few clinical trials and studies in people with scleroderma. Now, this is something that we're working on sort of more recently, but historically scleroderma has been a condition that has the diagnosis has often taken quite a while to happen. So to answer your question specifically, I don't know. There's no good guidance around this topic by any of our sort of guideline associations. What I say is I wouldn't routinely scope someone with scleroderma, not in the same way that I would routinely scope someone with Barrett's esophagus or something like that, but I would have a low threshold for rescoping someone with scleroderma if they develop new or worsening symptoms of dysphagia or heartburn. And the other thing is, again, this is guided by other complications. So for instance, if you have scleroderma and Barrett's, then you're being rescoped, but this is because of the Barrett's esophagus. And conversely, if you have a very dilated esophagus, we know that esophageal dilatation, esophageal stasis may predispose to certain types of cancer. So this is someone who may rescope on a more routine basis, maybe every 3 to 5 years.
And I would echo that as a person, as a rheumatologist. The way I approach this is I have a low threshold to refer. So if I see there's been anemia, if the reflux is very difficult to treat, if there's pain with swallowing, or if there's progressive actual dysphagia that is more than just mild, I would refer to my GI colleagues such as Dr. Wu.
Thank you. You mentioned one of the self-management things was weight loss. So someone is asking, what weight loss methods do you recommend?
I'm not sure which context. Maybe did I say weight loss was a symptom?
No, I thought it was one of the things we could do to help reduce reflux, I think is where it came up. Or maybe it was, maybe we misinterpreted and weight loss was instead a symptom of.
Well, I definitely think that like if obesity was a problem and that was worsening reflux, and then that might help. But in general, in my scleroderma patients, that is not the mechanism of the reflux. So I don't think I would recommend weight loss as a tool to reduce weight reflux. And I apologize, I have to look back in my slides to make sure I didn't put it in the wrong area or something. And in general, weight loss can be a problem in scleroderma. So I would worry about really going into too drastic diets. I mean, healthy eating is always good. But as I think a lot of you know, choosing the foods that work for your system is hard enough. So it's probably even harder to really try to diet.
Okay, thank you. This next question may have been answered already, but it says, when do you recommend that scope of esophagus be done? I think, is that what you just addressed that? So, okay. And then just someone wanting clarification that PPI should be taken 20 minutes before a meal instead of just some point daily.
Yes, that is correct. And this is again because of the mechanism of action of PPIs, because they block acid production, and acid production, or one of the situations where acid production is increases before your meal, in what's called the cephalic phase of digestion. So, we often see where people will kind of be taking a PPI randomly throughout the day. Some people take them before they go to bed, which doesn't really work as well. It's not the optimal way to take a PPI. The one exception being a PPI called dexlansoprazole or Dexlansoprazole. So the way it sort of, it has sort of like this advanced drug delivery mechanism where it has a delayed release. So in theory, it should be okay being taken at sort of any time throughout the day, but by and large, PPI should be timed with meals for the best efficacy.
And a question about gastroparesis, can it be sporadic, or is it once it develops, it's there, you have it all the time?
So yeah, I can answer that. So that's actually that's a very challenging question to answer, because we don't know a lot about gastroparesis. The stomach is actually, when it comes to motility through the GI tract, like the stomach is, it's way behind, where we are in terms of the esophagus and sort of the anal rectum. And they've actually done studies in patients who have a diagnosis of gastroparesis, where and these were people both with gastroparesis because of idiopathic causes, or they just developed gastroparesis and they had gastroparesis from diabetes or other stuff, and they just followed them. They repeated a gastric emptying study later on, and many of them actually resolved spontaneously. So if the question is, can gastroparesis be sporadic? I would say the answer, overall is maybe, because, again, the way we define gastroparesis is delayed emptying and gastric emptying test, which is, if anything, it's a surrogate measure of gastric emptying. And there are things like, we know medications can affect it. We know your diet can affect it. Fats will really delay gastric emptying. Blood sugars will delay gastric emptying. But I would say specifically in someone with advanced scleroderma, in that case, the gastroparesis is probably unlikely to resolve. So, if someone has, for instance, really severe esophageal dysmotilities or scleroderma esophagus, and they have impaired anal sphincter function because of damage to those muscles, I think it's unlikely that the gastroparesis or damage to the stomach will get better. But in someone without other features of damage from scleroderma, who has who's maybe on opioids or something like that, then it may resolve spontaneously. And then the other question I should sort of add is, the other thing that's very challenging is knowing, we know that people have gastroparesis. We know that gastroparesis is a delay in gastric emptying, but we know that many people with gastroparesis don't have symptoms. And we know that many people with normal gastric emptying have symptoms of gastroparesis. So there's a disconnect between gastric emptying and symptoms of gastroparesis. So that sort of leads to this idea that our understanding of what is truly gastroparesis is probably incomplete. And in patients with a delay in gastric emptying, increasing their gastric emptying does not always improve their symptoms.
Thank you. Is there a dose of PPI that is considered too high, both either as a daily and or long-term use?
I would say that there is no dose of PPI that is considered too high as long as you need it. So the reason why I say that is, for instance, in someone with an esophageal stricture that, we keep dilating, but it keeps coming back. This is someone who, if they go off of PPI, it's going to come back. In someone with Barrett's esophagus, we know that the risk of progressing to cancer off of PPI is very high. So, this is someone who is going to be on a PPI lifelong, essentially. And, some people need to be on higher doses of PPI. When you think about sort of how these drugs are designed, the high dose of PPI is the dose of PPI that works the best in whatever population of people that it was studied in. But the thing is, obviously, scleroderma patients were probably excluded from, these trials, these drug finding trials. And the other thing is, we know that individuals with scleroderma, they have many reasons as to why they would have reflux. Poor motility, poor lower esophageal sphincter function, gastroparesis. So, I would say that if there's a population group who would probably benefit from being on a higher dose of PPI in the longer term, it's probably individuals with scleroderma. And really, like I said before, the goal is to be on the lowest dose to treat the patient. And some people simply need to be in a higher dose for a longer term.
Is there a correlation with weakening swallowing muscles and motility issues?
I can try to answer. Maybe Dr. Wu can help me after as well. I don't know of any correlation if you're referring to the throat muscles that I was talking about, which are ones that you can kind of control, versus the motility issues, which are the involuntary muscles, the smooth muscles down the esophagus. I don't think there is a definite correlation there, although we do see that both of those probably a bit more often in scleroderma patients than in the healthy population. So there may be connection, maybe through nerve damage, for example, but nothing in the literature I've really seen to confirm that.
Thank you. And there's a question, just if you could, Dr. Mann, please repeat the name of the tablet you were referring to for nighttime treatment of dry mouth.
Yeah, that one is called Xylimelts, so Xylimelts. I can Does it help if I type it here? Oh, does that? Oh, I don't know if it showed up or not, but I typed it and it flew off somewhere.
Okay.
But they have other brands, and I've seen it when I've gone to the drugstore too, but I forgot the other brands' names. They all do the same thing. They're a tablet that has artificial moisturizer for the mouth in it.
And you would find that next to the toothpaste area. Okay, great.
Perhaps you could type it in the chat.
Oh yeah, okay.
Yeah. The next question, if you cannot have fundoplication because of Barrett's and you have gastroparesis, what is the next step?
I would probably just, yeah. So, one of the complications of fundoplication is what's called iatrogenic vagal nerve injury, which can lead to gastroparesis. So, you probably wouldn't want to do a fundoplication in this setting, but I would probably just treat the gastroparesis, either sort of with lifestyle modifications or prokinetics or, other modalities for treating gastroparesis.
And do you have any suggestions for dealing with fecal incontinence?
Again, I could start off the answer. Maybe Dr. Wu can supplement my answer. So what I have read about is useful, but I'm not sure where you actually get this done as biofeedback. So biofeedback you may have heard of for management of a lot of things, but is to understand when you're actually contracting versus relaxing and seeing it in front of your eyes, like using different detectors for muscles. So biofeedback, and it also helps if you have formed stools rather than loose stools. So addressing diarrhea issues such as small intestinal bacterial overgrowth, or dietary changes otherwise, so that you can have more formed stools. There are also newer techniques that I've read about, but I don't know if are actually implemented. I think my GI or surgery colleagues might know better. So those include things like injection of certain things that will make the sphincter more fuller, so it's tighter, and also electronic stimulation kind of implants, so that again it'll tighten things up. Dr. Wu, do you know of any other?
Yeah, so again, fecal incontinence it's a complicated topic, and you could probably have a bunch of other lectures about that. But to add on or to echo what Dr. Mann said, I would say the number one thing with dealing with fecal incontinence is solidifying the stool. And the reason why this happens is actually it's physiologic, because you have within the anal canal itself, you have these nerve receptors that are really good at differentiating between solid and you have these receptors that are really good at differentiating between solid and gas, but not so good at differentiating between sort of liquid and gas. So this is why there are many people who might say, yeah, I thought I was going to pass gas, but I passed stool instead, and it's just because your body sort of lacks, in many cases, lacks the ability to discriminate between the two types of a stool, essentially. So the other options that we have sort of for fecal incontinence, you can use these sort of plugs that you can kind of put in as sort of mechanical barriers. You can use bulking agents. You can use, I have some patients who, you can kind of try using like an enema bottle before you go out to just sort of empty the rectal vault of stool. Now, the challenging thing, so about biofeedback. So, again, to sort of add on to what Dr. Mann said, biofeedback essentially you work with a physiotherapist or, especially someone who sort of specializes in the pelvic floor to really work on, strengthening the muscle. But the challenge with scleroderma is scleroderma affects the smooth muscle. And your smooth muscle is your internal anal sphincter. That's involuntary muscle. So that's why many people with sort of scleroderma involvement in the anal sphincter may have what's called passive fecal incontinence, so leakage, as opposed to active incontinence, which is urge. And in these situations, exercises may not work really as well. the neurostimulator is not, it's not really done in many centers here in Canada, and its mechanism is actually by sort of increasing the sensitivity of the rectum, because one of the things that sort of contributes to incontinence is this whole idea of rectal hyposensitivity. So you don't realize you have stool in your rectum. So because you don't know you have stool, you're kind of going out and about, and you may have leakage because you have this buildup of stool in the rectum. So, you know, the neurostimulator has been shown to help in those cases, but not commonly done here in so, you know, I would say that the main thing is, you know, to really try to bulk up that stool.
Thank you. Okay, we only have time for just a couple more questions. So I'll just select a few here. So you mentioned probiotics is not necessarily recommended. Should someone with SIBO steer away from yogurt with probiotics?
I think yogurt with probiotics is okay.
Okay.
Yeah.
Great. Is there anything, if the motility in the esophagus and small intestine, if things are just starting out, if it's the early stages, can you do anything to delay progression?
So unfortunately, as far as I understand, there is no way to sort of delay the progression, because a lot of what we do, at least in GI, is to sort of, you know, manage the symptoms associated with that stuff. Now, to be honest, I'm not 100% sure if other immunosuppressants used in the treatment of scleroderma have been shown to delay progression, but I don't think so.
All right. Okay, and just one last question. Dr. Wu, can you please repeat the name of the prokinetic agent you use in bacterial overgrowth?
So the medication is called prucalopride, or its other name is Risocren.
Okay.
And I can spell them in the chat as well.
Okay, perfect. And one last question. Someone has said, my dentist gave me a prescription for increasing saliva production. Do you have any thoughts or comments about that?
I'm not sure what that, I thought that was the name of the prescription. Yeah, so there's something called Saligen. That might be what you were prescribed, and we do prescribe that, but I'm not aware of dentists usually prescribing that. And it can help increase saliva production, but it can have some side effects as well. Sometimes it can lead to sweating or runny nose and hot flashes. So it's not a very well tolerated medication, if that's the one you're referring to. And sometimes it's just trial and error with that one.
Okay, well, unfortunately, we still have a few more questions, but we are running out of time and we'd like to wrap it up. So if Dr. Wu would perhaps stop sharing, and I will share mine. I would just like to say a huge thank you to both Dr. Mann and Dr. Wu for your very informative presentations today. We had a number of comments thanking you for your great presentations. And the Scleroderma community from across Canada, thank you for your time preparing for and presenting this webinar and your efforts to help scleroderma patients each and every day, in fact. I just want to quickly remind people about our next online support group meeting, which will be held on January 22nd at 10:30 a.m. Where we'll have virtual breakout rooms and we can discuss various symptoms and ask each other questions. And you can visit the Scleroderma Manitoba website for more information. Thank you so much to everyone for participating today. If you have any feedback or comments about this webinar, please email Scleroderma Manitoba. Most importantly, remember that as a member of the Scleroderma community, you are not alone. And so with that, I'd like to wish everyone a great weekend. And thank you again to our doctor presenters. And I thank you for joining us today.
Thank you.
Thanks a lot, everyone.
Okay, thank you, Geraldine and Debbie and Diane.
Thank you.
And
Bye.
nice meeting you.
Okay, nice meeting you too, and thanks again for the opportunity to sort of
Yeah, thank you.
Yeah.
Thank you.